Okay, we'll get started. Hi, everyone. Thank you for coming to our first ever Critical Care Rehab Expert Panel Speaker Series. Today, we're going to be talking about ECMO mobility with four of our ECMO geniuses. Thank you so much for being here. We have Jenna, who's going to be joining on at the halfway mark. Unfortunately, Instagram only allows four people to go live at a time. So about halfway through, we'll switch Jess and Jenna out. So to introduce our speakers, well, first, my name is Anna Mazmanyan. I'm the person behind Critical Care Rehab. And with us today, we have Erin Thrush from Cleveland Clinic, Abu Dhabi. We have Stephen Ramsey from Atlanta, and we have Jess from Florida. Thank you all so much for being here and taking time out of your lovely Saturday to answer some ECMO questions for us ICU nerds. Our first question, the question that we probably got the most from everybody is, what are the cutoff values for settings, parameters, ECMO settings, ABG values, vitals, vent settings, basically all the numbers? What are the numbers for being considered medically appropriate to mobilize an ECMO patient? And is it different for VA versus VV?
Well, Jess, should I start with adults and then you want to do peds maybe?
Sure.
Okay. Well, I don't know that many people are going to like my answer, but
Probably going
it's
to be the same as mine.
yeah. So there's not right. There's not one lab value, right, and there's not one kind of critical level that I would look at. I think the big picture, and I'll speak for VA first. I think the big picture is these people are in, somewhat of a shock state, right, when they get cannulated for ECMO, and is there evidence that perfusion is improved and they're emerging from a shock state? So, yeah, you could look at lactate and you could look at ABGs and all that stuff. What I want to see is that trend is towards we're stabilizing, we're coming down on pressors, our end organ function is starting to improve, and that's when you know it's time to start, initiating mobilization. So I think early days, if that's not happening, if they're up on pressors, if they're in a metabolic acidosis, if they've got a high lactate, if they've got a CK that's climbing, that tells us that they're not actually perfusing the body. So adding more metabolic demand and oxygen demand is not going to help the situation. I think that algorithm changes though when someone's been on for a long time. Like if you think of your patient that's been on for weeks to months and you see that they're kind of slowly deteriorating, I actually kind of throw that out the window and continue mobilizing even in the setting of maybe worsening end organ function. So I think it does depend on where they're at in their course for me.
And I think for VA and PEDS, the other caveat, it's very similar, but the other caveat you have to understand is what the underlying anatomy and physiology of the child is, because a lot of these kids can be congenital kids with congenital heart defects. And so sometimes your goals and what your perfusion looks like, and some of that can be a little bit different. I think just considering where you're at and how much room you have to go up, because we generally don't do a whole lot with these kids if you don't have a lot of room to go up. The exception is sometimes, even if they're really pretty sick and they're not looking so good, one of the things we will almost always do is get the baby or the toddler out of the bed so that mom can hold or dad can hold or whoever their primary caregiver is can hold, because that can often be very comforting for them and can actually really help turn things around and decrease the sedation need and things like that. So that's kind of the PEDS VA side.
Yeah, maybe I'll quickly speak to VV. I think it's a little bit different because you're not really kind of approaching this perfusion shock situation as much. And so again, maybe this is not a great answer, but I don't really look at PO2 because the anticipation is that they don't have a great oxygenation. And we're supporting them from both an oxygenation and ventilation standpoint from the circuit. And so with that being said, I mean, we're returning a partial pressure of 400 or 500 through the circuit. And if you've noticed on VV, what actually makes it to the arterial side is quite a bit lower because there's so much of that kind of diffusion in the lungs of that oxygen that's actually going in. So I don't really consider PO2 or SAT when I'm making my decision. I do consider amount of support. So if they're maxed on vent, maxed on ECMO, and not tolerating rest, then not that we shouldn't do something, but we would need to consider what we're prescribing, and are we going to increase demand? And they're not ready for
Titrate your activity accordingly.
Exactly right. Yeah, and so there's always something we can do, but maybe it's not running down to Starbucks at
The
that
other
point.
thing I pay close attention to is like the plasma free and what the post-MO gases look like, because it gives you an idea of how much life you have left in your pump. And
Yes.
so if your pump's nearing the end of its lifespan, you're probably not going to be able to max it out like you could if it's really fresh. And so I think that's something to consider too when you're thinking about how hard you're going to push your patient.
Yeah. And I think Jess will probably agree. All of this is weighed in the context of, can we maintain flow consistently through activity, right? So they might look a certain way at rest, and you start to kind of initiate some mobilization. If they can't maintain flow, then the whole algorithm changes. They're not supported as much. So
It's
trying to
kind of a
troubleshoot that.
constant multidisciplinary collaboration and decision making with every position change and every change in activity throughout the entire intervention.
Yeah, totally agree.
And I will say it also depends on your hospital, right? Your risk calculator, if you will, in terms of who you're working with, your environment. And it might be different at a transplant hospital versus a small community hospital, a hospital that's been doing this for decades, and a hospital that just started doing this. You have to consider the medical team's competency in kind of managing the medical aspect of things when deciding how crazy you can be, right?
And I think when thinking about starting a program, because I helped start our program, your patient one, like you want it to be successful. So you want to kind of pick that patient that you know is not maxed out and is probably going to tolerate it well and is kind of going to be a stable slam dunk that looks pretty good. So when you're thinking about starting a program, you might skip over a few patients before you get to the one that looks like they're going to be the most successful, so that you can kind of get team buy-in for the first one and then continue on from there. We didn't put kids on bikes the first time we got.
In case people are newer also to ECMO or even the ICU, just starting with the basics, right, of your neurologic and cardiac and pulmonary systems is, I think, probably covers maybe 80% of that screening already. So you have to be very familiar with that. And then I would add also, as someone already mentioned, the interdisciplinary approach, and how I usually advise people is, each of these cases is very different, right? And the risk benefit. So when we have our standard parameters, I think with ECMO in particular, we find ourselves with exceptions to those parameters. So usually going to the team and showing that you're an informed therapist, saying, I know this is the current status of the patient, this is the trend of the patient. To remind you, these are our normal parameters. They're outside the parameters, but let's talk about, what we might still be able to do and that risk benefit. So that you come with context and then can move forward with decisions.
Yeah, I think that's important though, because we play a big role in that. So we're not passive as part of that conversation. So something I would be curious y'all's thoughts on. I think the more we understand about the medical decision making and how the team would respond in emergent situations, the more aggressive we can be, because we understand,
Absolutely.
Is this treatable or is it not? Is that something you guys have experienced?
Absolutely. And kind of what the end game is and the goal and the trajectory and what we're working towards.
Yeah.
Great.
I guess
You.
like longer term, like what's the trajectory and outcome we're going for, but also when you raised, I was thinking like within the session, what's the plan and if things begin to go in an unexpected way. So it's the short term and the long term. What can the team deal with and how, right?
Yes, I totally agree in terms of what's the plan and kind of having some wiggle room on one of the life support machines, whatever they're on, whether it's ECMO, the vent, pressors, inotropes. If you have no wiggle room on anything and you have an emergency where you need to increase support, if there is no support to go up on, I think that's a great point, Aaron, of like, what's the medical plan if we need to give the patient more support? Do we have enough wiggle room to say on any of the devices to do that? Thank you all. The next question we have is, there's various different cannula configurations, right? And what are the different mobility implications and considerations for each configuration? So, we often hear the fear of like femoral cannulas and hip flexion, and I know there's like some tests and tips and tricks for all of them. So, would love to hear what tips you guys have for each cannula configuration.
I know from my experience, we've with physical therapy and our rehab and the ECMO patients in general at our center, we're most familiar with bilateral femoral and femoral jugular, and to a smaller dual lumen cannula in the jugular location. But I would also just say that if you look at evidence and publications, you can find evidence that supports safe, feasible mobility across all the configurations, to the point where recently, central cannula and other things that I even have trouble visualizing because I've never seen them and just read about them. So I think the important part is knowing what your medical team's approach is, and also that they, as much as possible, are considering how their choices are going to affect you as well. And it may be less about the location and more about, the length of cannula tubing that you have, the securing strategies, what's the quality of that, and how well are the nurses kind of carrying through that, and the checks that you would do. So I think it may be less sometimes about the location, because we can see that it's safe, and more about some of the other points perhaps.
I think considering like the skin integrity of the patient too, because sometimes those chronically critically ill people, just the skin integrity is quite poor. And so while they might have every suture under the sun, those sutures might hold for a day. And then you're less secure than you once were. So I think just every time paying attention to the securement and having a close collaboration and conversation with the surgeon or whoever did the cannulation. I think it helps to have an understanding of perhaps how difficult the cannulation was, and understanding not that you ever want it to come out, but if it were to decannulate, how difficult was it to get in the first place, and kind of what considerations, is that the only available vessel? Are there other options? Just thinking big picture, not that you ever want something bad to happen, but I think it's very important to be very prepared for every possible outcome.
Yeah, I think it's good to talk to the cannulating physicians as well. I mean, I think they'll give you some insight on how easy or difficult the cannulation was. Is it surgically grafted and they feel great about whatever you're going to do? Is it percutaneous and they had some difficulty accessing the vessel? They felt like the tissue is pretty friable. I think that those conversations are important. And the only thing I would say from like an interesting configuration is we do a lot of like transeptal cannulation strategies, a transeptal drain to unload the left side of the heart. And a lot of people do like Impella with ECMO for that. The only thing about that particular strategy, if anybody else does that, is that we typically only roll them right, so as not to kind of pull the transeptal drain across the septum. And then you just have this additional line to monitor. Is it still in the left atrium? Is there evidence of pulmonary edema? That's the only one that I actually think differently about when I mobilize.
And we did have a follow-up question for this in terms of the hip flexion test for femoral cannula patients. And if hip flexion test is failed, would that mean automatically you're not able to mobilize with femoral cannulas? And then specifically for bariatric patients where the weight of the pannus, the weight of the abdomen, is both compressing and pulling down in a downward way, what tips you have for those?
So for the hip flexion kind of failure, no, I don't. I think it depends on what the failure is. Is it flow? Is it hemodynamic? Like, what's the failure part? If they're talking about like they have a bunch of flow variation with hip flexion, then I think we can try strategies for that. And maybe it's as simple as like their CVP is 2 and they're, pretty euvolemic to hypovolemic, and they can do with some volume, and maybe that, plumps up their vena cava or their aorta a little bit more. And, if that doesn't work, then maybe like a colloid, something like that, some albumin or something might help. But that would be my only thought.
Thank you, guys. Our next question we have is, what lab values do you look at when considering if a patient is becoming appropriate? Not necessarily cutoffs, but more which numbers are you looking at and what trends are you checking for each one? And if some of the lab values are going in a negative direction or they're declining, which values would you kind of hard stop for, or versus, we can kind of get away with this?
I think it kind of goes along with what we've already talked about. I don't know that I don't have any black and white answer for any of them. And I kind of look at the big picture of the patient and the big picture of the direction that the patient's trending, and where we are along their trajectory of care. How long have they been on? What are the goals? What are we headed towards? Is this like a patient of ours that's maybe waiting for a heart, liver, kidney transplant, in which case I don't expect the kidney or the liver numbers to look good? And they're probably on CRRT in combination with ECMO, and so that's not going to preclude us from mobilizing the patient. And so again, I think it's just looking at the big picture, understanding the big picture, understanding physiologically where the patient is, and thinking from a multidisciplinary team standpoint of where you can go from here.
Yeah, I totally agree. I think we mentioned earlier, but what do the lab actually tell us? So what does lactate tell us versus CK? What does plasma-free hemoglobin tell us about hemolysis? Like these things, I think, again, understanding what the labs mean help us make the determination, but it's always big picture. It's always, I think it's tough. I don't want to generalize, but I think it's tough for the rehab team sometimes to think as part of the medical team, but that would be the encouragement, is have these discussions with them and hear their thought processes on these, and then provide your input from there. Is how it started for me, and then it's kind of evolved from there. But there's not a lab value, like again, hemoglobin of 4, let's mobilize, right? Like I think there's no cutoff for much of anything.
Jess, we specifically got a pediatric question before we swap you and Jenna out. In terms of kiddos with ARDS and disconnecting the ventilator for mobility, can you talk a little bit to that and what you kind of do with the vent before mobilizing with these patients, you and your medical team?
So our medical team, especially with our younger kids with ARDS, actually tries to wean off the vent completely and just use non-invasive support or high flow. Depends on whether they have a trach or not. If we've trached them, then sometimes we'll just do high flow through the trach, and we can do inhaled nitric or through the trach with the high flow if we need to. But we take more of a like full rest approach with our littles. So we have had ARDS toddlers and infants on VV that have been really on high flow through their trach for their entire 6 to 9 to 12 month run, if they can maintain their weight. Usually it's kind of from a work of breathing standpoint, and as long as their work of breathing is okay and they're maintaining their weight or gaining weight appropriately for their age, then we minimize the use of the ventilator as much as possible, which then makes it easier to mobilize down the hall when you're thinking about this little tiny human and all the things you have to drag with you to mobilize them outside the room.
Thank you so much, Jess. We're going to do a quick intermission where Jess logs off and we add Jenna, and then we'll continue on with our questions. Let's see here. Hey, Jenna. Thank you for joining us.
Yeah, of course. Can you hear me okay?
Yes, perfect.
Okay.
Okay. So our next question we have specifically is for program development, uniquely for underprivileged hospitals that have limited resources and are just starting their ECMO program. So like the medical team is kind of still learning how to do ECMO. The nurses are still learning. The ESs are still learning. Everyone's kind of learning as they go. And you're not in an academic hospital, you're not in a transplant hospital, your hospital might even have poor funding. So access to experienced therapists is very limited. Sometimes as a new grad, you're the only person that has experience working with ECMO, and that experience is maybe from a clinical rotation. So we got a bunch of questions from people in these similar circumstances where you're not a transplant hospital, but they're learning to do ECMO, and difficulties launching a mobility program while the ECMO program itself is still launching, and how you go about that.
Who wants to take that, Aaron?
I'll start off. I don't know that I can answer the question very well from a kind of a community hospital setting. I think it shows that we need to build our networks a bit and learning from each other, because each of us often are where we are for a number of years, and we don't have that exposure to what other people are experiencing. So again, from my experience, we started our whole thing with COVID, and we had a very small ICU physical therapy team, very operating at a very high standard, but none of us actually had ECMO experience prior to that. We weren't a transplant hospital, we weren't an academic hospital at the moment. We developed all that in the years after, but we were really developing our program on as COVID was happening. And so in the beginning, it was very reactionary. We were learning from our physicians and perfusionist colleagues about what we were seeing with ECMO, and at the same time with a disease process that nobody really understood either. We went from a very reactionary kind of learn in the moment. We couldn't even talk to each other to learn about things at that time, right? We had a spreadsheet where we would share observations and then like virtually figure out what we were seeing. And we moved from that to a more systematic way of developing our program once COVID kind of, we began to manage it, or it began to diminish. So I think the experiences would be very, very different for people. I would mention the framework that me and my colleagues published earlier this year. It again won't speak to the individual challenges of different kinds of hospitals, but I think it was a way that we found helpful to zoom out a little bit and say, what are the many components of building a program and then sustaining a program? Because in my experience, I found you can go to the literature and find out, you can get ideas about screening and eligibility and mobility progressions and who should be part of the sessions. But after a while, I felt the bigger question was like, well, how do programs actually set it up and make it sustainable? So I'm not sure that answers the question very well, but I guess there's so much variability to what each of us experience.
I think that was a great answer. And a follow-up question we got was specifically how to prepare for ECMO from a mobility perspective when you know you're going to get an ECMO patient. And a lot of the barriers we face is like lines not being long enough, or the way things are placed in the room, and suturing, cannula setup. A lot of that happens during cannulation. So what are some tips and tricks for kind of how you're involved before that, like pre-mobility planning?
Steven, I'll let you answer that one.
Well, yeah, I think face-to-face time with the team is really important. So I think explaining the needs that you have and the strategy that you would have to mobilize a patient, and then add the tubing in with that and the equipment that's in the room, and walk them through why what they did the first time maybe was a barrier, and why that would be helpful next time, what to add more length of tubing, or to think about suturing differently, so that we're not remedying it on the back end. I think the beautiful thing is the medical team doesn't want to have to think about that. So be the person that thinks about it, right, for them. And I've never personally met resistance, nor do I think it's something that we would meet resistance on if we're trying to think for the patient in that way.
Yeah, I've kind of been in both instances where like we started out having to remind them of it on the back end, and then people always want the patient to be able to meet success with mobility, because mobility means survival, and a lot of the times. So I've never really met resistance in trying to get them to change either sutures or anchor spots or that sort of thing, and just helping the team learn as you go about it too, so that then they start to think about it on the back end too, and explaining why you're asking for these changes, not just saying, hey, can you do this?
All great points. Thank you. And another big one sometimes we do is talking to the surgeon about the importance of the cannula locations and the suturing, because if they know how much of a barrier it is, for example, if they suture like right on top of the patella, then you can't bend the knee. So knowing these biomechanical issues before they cannulate really helps, like educating your surgical team. And then also collaborating with nursing, picking the biggest room before the patient arrives, making sure you kind of set up the room for success, making sure machines aren't crossing over each other and you're turning the bed. And there's a bunch of pre-planning you can do with nursing to make sure like your room is set up for success. Thank you all. We have another question. Specifically, this is the original question that led to this panel being formed and this speaker series, but we got a question about over-aggressive / dangerous ECMO mobility. And the circumstance for this was a situation where a hospital had just started their ECMO mobility program, and they went from one extreme, and as Erin said beautifully, the pendulum swung way too far onto the other side of strict bed rest to trying to transfer someone with a high spinal cord injury without knowing the implications of that. And I think what the original poster's concerns were is that transferring someone with a high spinal cord injury with all these trauma, weight-bearing precautions is a very different transfer than your typical ECMO patient. And I think it seemed like there was maybe some gaps between rehab and nursing in this situation of, you know, it's great for there to be nursing mobility protocols for ECMO and all mechanical circulatory support, but there needs to be a clear understanding of when the case is too complex physically and to wait for PT and OT to kind of initiate mobility. And I think this was a situation where the original poster maybe felt like nursing wasn't really understanding why there would be anything different and why like the medical team should also comply with the rehab precautions.
I think this is like where we as rehab professionals have a very unique spot at the table. To me, just kind of outside looking in, not knowing all the details of the case, of course, it just seemed like there could have been better communication overall. And kind of being the person that leads that communication, specifically with mobility. I think that, you know, the best kind of place for this is interdisciplinary rounds. And I know that I've worked in places where they give you time out of patient care to attend rounds in the ICU, and then they don't. And as somebody who was like getting mobility started at a certain hospital, I would insert myself into rounds and make time for rounds, because the value is just, you can't like there, you can't put a price tag on the value of attending rounds and kind of forming that place at the table, because you are the mobility expert and you're the one that's thinking about all those things and making sure that everyone else on the team is kind of keying into those things. And even if like you, often we hear, well, we don't have time out of patient care, I have very high productivity requirements, that sort of thing. You can even do kind of speed rounds in the mornings with the providers, like, hey, these are the people on my radar. Please make sure that you bring attention to these things when you guys are talking about rounds. These are my concerns. These are the things that need to be highlighted. And then you can still, you know, plan your day and get on with seeing all the patients that you can. I don't know if you have anything to add, Stephen.
Yeah, but I think back to the original question, I think it's such a delicate balance because I
Yeah.
think, and there's programs, right, where the nursing and medical team is actually further along the path of mobilization than the rehab team. Sometimes the
Yeah.
rehab team's kind of jumping on, and I don't know that that's the case with this original question, but it's sometimes we're catching up and sometimes we're pulling the reins back on the team, but you never want to like squash the enthusiasm of the medical team to mobilize the patient. I do think that there's an important ownership of precautions around mobilization. If we're not the expert in that, then I'm not sure what purpose we serve. So I think solidifying ourselves as the people that are experts in the moving the patient part, not that we have to be there every time, but we at least speak to how. And usually what we've done at our hospital is, hey, let us do the first time. Like, let us see what it looks like the first time we mobilize this patient. Let's think about some of the precautions and how they respond so that that's off your plate to think about as the nurse or the
Yeah.
ECMO specialist or the physician. And then if it goes well the first time, like, y'all do whatever the heck you want. Like, just do it this way. That would be my only feedback. Again, not knowing the entire situation.
Yeah.
I think that's a great point, especially making sure your nurses and your medical team know that you're readily available for them to call and text you. A huge ask from
Yeah.
our nurses was that they want to have direct communication with PT instead of having to call the department phone and then Epic chat. And, ICU, they want fast turnaround. Most ICUs have like every doctor's phone number posted. Nurses can text, call, and our nurses express like if we had that option for PT where we have like a direct lifeline if something happens, a PT to call and text, and kind of giving, there isn't many like algorithms out there on this, but you can create one for your own hospital of like, if this happens, text PT, or if these situations come up, these are instances where you would want to wait for PT to come before, so that, like Steven said, you don't crush the enthusiasm of them being proactive, but you're giving them like a lifeline of when situations come up that they're not the most comfortable with. Thank you all. Those are great. One last question before we go to questions from the chat. So specifically for verticalization therapy, this has become huge in like the last few years, and standing beds. And a lot of questions we got were about like strap placement for these patients and how it's dependent on where the cannulas are placed and how they're sutured, and what implications there are for the strap placements and what different options there are. And if someone does fail the hip flexion test and failed, whether it's chugging, bleeding, oozing, extreme flow reduction, would you still be able to adopt the Ramsey protocol from femoral balloon pump in a patient with a femoral cannula for walking out of the verticalization bed?
I'll kick that one off. So there's lots of different ways with strap placement. You can get really creative. Standard strap is somewhere over the thorax, depending on what lines they've got going on, above the knee, below the knee. But you can get creative. So like with a lot of pediatric patients where the patient is smaller than the bed, or just, some of the, other ethnicities that often are shorter, you can do like a seatbelt technique, especially if they do have like some sort of axillary cut down device and you're trying to miss that device. It can be a little more comfortable for women to do, a crisscross technique. So you can crisscross the top two straps or do seatbelt. You can get really creative in some of the poly trauma. If they're single weight bearing on one leg, you just leave that leg out propped up on a bolster and strap in the weight bearing leg. You can really get creative with it. As far as cannulas, so sometimes, patients may have short femurs and it's really hard. Usually we say run your anchors either inner thigh or outer thigh or your sutures so that you're not putting that strap directly over your cannula. Sometimes when patients have short femurs, you just can't avoid that in every sense. So usually I'll instruct to just fold a towel or a blanket and place it over the cannula in between your strap, so that if your strap is getting a little bit of shearing, you're shearing that folded material and not the cannula itself. And then of course, just keeping an eye on your cannulation sites throughout mobility, just like you would with traditional mobility. As far as, if they are failing the hip flexion test, of course, and you guys could disagree with this if you want. Of course, verticalization is always a good option. It doesn't always have to be on a bed. If you don't have access to those beds, it can be on other devices. There's lots of great devices out there, and most units or most rehab departments have an old school tilt table and can get started there. And that's how you can kind of justify paying for other devices for your program, that sort of thing. But it's certainly a great option. And if you are getting pushback from your surgeons on femoral cannulation, it's a great way to get your program started. So building trust in everyone and getting those kind of that team chemistry down with mobility, your protocols in place, that sort of thing. It's a great way that you can start your mobility program, and then people will typically get a little more comfortable, and it's like, okay, why are we limiting them to just a standing bed when they can, are clearly strong enough to stand up and walk out of the room, that sort of thing.
Yeah, I don't have much to add, to be honest with you. I think it's a great tool to have when sitting upright is not tolerated. I would say that it doesn't replace the, like, let's figure out why it wasn't tolerated. So,
Yeah.
like, is this volume? Is this cannula position? Is it habitus? What's the limitation? Because there's certainly some benefits to sitting up on the side of the bed and then sitting in a chair. But I do think it's a great tool, early days, and for those people that aren't tolerating edge of bed. And it's great too. This is not VA femoral, but like your VV femoral that are like have been on industrial strength versed for 3 weeks at an outside hospital, and they get sent over and it takes them 3, 4, 5 days to wake up. Like the tilt bed is great. And this speaks to an earlier question. Sometimes we'll anticipate those people transferring over and know they've been in another hospital for 3 weeks and go ahead and put a tilt bed in their room and start that day zero, like on admission, just start tilting and kind of go that way so we can get them up as early as possible. So it's definitely a good tool.
Thank you all so much. Now we're going to move to some questions from the chat. We did get a bunch of questions about competency. I'm going to save that for our second speaker series because we're going to have some rehab educators that work in specifically competencies and training. But a great question we got is, what are the 1 to 2 biggest things that you feel newer clinicians miss when mobilizing ECMO? And it's open-ended, so miss can mean miss in terms of like, what are you missing medically? What are you missing planning wise? So missing in any context.
Aaron, why don't you start with that?
Sure. From my perspective, I think the thing that I find myself coming back to over and over again with people who are going through, for example, the orientation and the competencies, is the planning and the communication. I don't know if that's unique to where I am or not, but when we have our list of expectations about what's happening in a mobility section, that list is like the top 2/3 of the page is pre-mobility, and then the last third is the during and after. And I think it just requires a whole enhanced way of communicating, and the physical therapist in most places is the central figure in planning and carrying out and directing those mobility sessions. So communication needs to be clear. People need to know what they're responsible for, when they're supposed to speak up, how they should communicate, keep communication really streamlined, coming from one person to the patient often. Again, what's the stop procedure, or under what conditions are you going to stop? How's the patient communicating in case their communication is not normal and verbal? So everything, the plan, the goals, again, how you're going to navigate out of the room, all those things, I think is often the thing that I find myself trying to drill more and more with people, because things can unravel quickly, and if you don't have a good foundation of that communication and the team dynamics, then it's really hard to make this work well.
Great, thank you all. Another question we got is, do you approach bridge to recovery different than bridge to transplant in terms of activity intensity? And I think we can also expand on this when it comes to parameters and cutoff values. I think the approach question is for both treatment and your parameters. If someone's planning on staying on 100% FiO2 for 5 months, with a lot of patients waiting transplant, they're kind of riding stable at 100% FiO2 for like weeks and weeks and weeks, versus someone that's bridge to recovery. Also tying in with another question we got, at hospitals that see ECMO patients very sparingly, what is your activity intensity approach for bridge to recovery versus transplant?
I can honestly say I don't approach that patient population, those two, differently, because I think if you're talking about the bridge to recovery that is maybe not a transplant candidate, or you're at a non-transplant facility, your goal is to get them the heck off of ECMO and out of the ICU, right? I mean, that's the goal. So we need to promote early and often mobilization and rehabilitation to achieve that goal. And if it's bridge to transplant, your goal is to get them from prehab standpoint as ready as possible for whatever that next step is. And we don't really know what that next step, when that next step will be, for heart or lung or others. So I think I don't really approach that patient differently, in my mind.
Yeah, I mean, if you're looking, especially, I think my most experiences with VV and like end organ failure, versus like crash and burn into ECMO. They're both going to look pretty bad in the beginning, but your end organ function, they're going to look pretty bad for a long time, especially if how much native function they have left, especially in VV. And so like you know, especially in a program where they're starting their ECMO mobility, you know, this patient may be on 100% on the circuit and 100% on the vent for a long time because they just have their lungs are shot. And so like you're looking at that patient slightly different maybe than one that's in full-blown ARDS, and you don't want to quite be as super aggressive in the very beginning, but you just have to look at what the overall goal is. But for both of them, you know, you're going to want to be as aggressive as possible.
Can I add one thing to the, sorry, I don't want to go back. I want to just one thing to the like biggest things newer clinicians miss, because I had a thought. I actually don't think it's like the specific lab values, because I think this was in the context of like assessing readiness. I think it's actually putting it all together with your physical exam that Aaron mentioned, your cardiopulmonary exam, your neurovascular screen. Like it's putting all the pieces together to make one kind of solid plan. So I just wanted to mention that. Sorry to jump in.
Thank you guys. That was great. We have a few more questions. I know we're going a little bit over time, so if any of you need to hop off, that's totally fine. We got a question about ECMO hospitals that see ECMO very sparingly. What we talked about earlier, the small community hospitals with not a lot of resources, specifically finances, and how PTs can get more hands-on experience. And we did have somebody mention in the chat recommending a few companies. That if you guys can look in the chat, I don't want to say any brand names on live because of Instagram rules, but there are companies that do hands-on training. But if you guys have any additional tips and tricks for how to get experience when you have limited resources.
I'll also add to that. Yeah, there's some great companies that have been mentioned in the chat that I've seen. Unfortunately, there's very few like sim courses that exist for therapists, but there is a lot growing out there. I'll give Stephen a little shout out. He's creating a course for MCS, so look for that coming soon. But also just like there's a lot of peer mentors out there. So like reaching out to any of us, and trying to build that research or that resources and network, is you can learn a lot from your peers, and doing kind of virtual mentoring if you don't have a mentor in person. I am very spoiled because I got to train under this guy here, Stephen. But being able to build that network outside of opportunities that you might have in your own hospital, there's a lot of resources that we can share. And I always say, like, what are we doing if we're not sharing our knowledge? So reach out to people and don't be afraid. We're all super approachable, always happy to help whoever we can.
We've been able to have a lot of interest and carry through a little bit with actually having people visit our hospital, or me going out to another hospital. And I haven't been in the US for about 10 years. I don't know if there's maybe more barriers to that than where I am. But we operate all of ours through our academic department. And so people can come in an observership and an internship. I mean, that's probably not the route that, licensed therapists will go. But, again, maybe just along the lines of what Jenna said, if you reach out to people, I think everybody wants to make these things happen. And so even observing each other in our practice might be something to try to pursue. We've been pursuing that, and we have people doing that where I am, which is really nice collaboration.
Yeah, talking to your leadership as well. sometimes we don't have a lot of dollars in therapy departments, but something I've learned along the way is if I want a piece of equipment or some sort of course offered to us, going to the ICU leadership about it as well, because they have a bigger pocket. And you just have to advocate for yourself and have a good, justification of why you guys need these things and how it would benefit your hospital, because there is data behind it to back it. You just have to put in the work to show it to your leadership.
I think that's a great point that Jenna brought up in terms of asking other departments, because surgery departments have a lot more money than therapy departments. And a lot of surgeons are very supportive of mobility. A lot of intensivists are supportive of mobility. And it doesn't hurt to ask, writing a nice little letter explaining like what you want, what you need, if there's a course you want them to pay for, if there's a hands-on training experience, equipment, writing a letter to either executive leadership or your director and just explaining why this would be beneficial to the hospital, and asking if there's any like private donors or foundation money or surgical money, and seeing what other options they have. Another thing would be to potentially get a temporary per diem job at a transplant hospital just to learn ECMO, kind of doing like the bare minimum shifts just so you have an academic hospital to get your foot in the door, and then taking that knowledge with you to your community hospital. Thank you all so much for your time and for answering all these questions. We will be posting the recording shortly, and it will also be up on my website. We're definitely going to do more of these in the future. So if you guys have any questions that you feel wasn't answered, please feel free to send them to me, and we will plan them for the next speaker series. Thank you all.